in 3D, in 3D ultrasound imaging and imaging-guided megatronic interventional systems. Throughout his illustrious career, Professor Fenster has established himself as a trailblazer in the translation of cutting-edge technologies from laboratory to clinical use and commercialization. His expertise has led to the development of revolutionary applications such as the 3D ultrasound guided interventional system for prostate biopsy and brachytherapy, breast brachytherapy, and focal liver tumor ablation. Under his guidance, Professor Fenster Laboratory has produced an impressive body of work, including numerous peer-reviewed manuscripts, conference proceedings, books, and book chapters. Additionally, his contribution to the field has resulted of 53 patents and 14 licenses, showcasing the practical impact of his research. Not only has Professor Fenster excelled in advancing scientific knowledge, but he has also played a pivotal role in mentoring and nurturing the next generation of researchers. He has directly supervised a substantial number of doctoral, master's, and postgraduate students, fostering their growth and fostering a legacy of invention. Recognized for his exceptional contribution, Professor Fenster has received numerous awards, including being named the Order of Ontario in 2020 and being elected to the Royal Society of Canada in 2022. These honors underscore his significant impact on the scientific community and his dedication to the advancing healthcare technologies. We are privileged to have Professor Fenster join us today as our distinguished speaker. His expertise, research accomplishment, and dedication to the advancing of medical imaging and interventional system will undoubtedly enrich our understanding and inspire new possibilities in this rapidly evolving field. So please join me to extending our warm welcome to the Professor Aaron Fenster. We eagerly anticipate his enlightening presentation and the valuable insight he will share with us during this webinar. So Professor Aaron Fenster, the floor is yours.
Oh, thank you very much for the introduction and for the invitation to describe some of our work to you at far away from where I am in London, Canada. So now I'll share my screen. And okay, so I assume you can see my screen now. So as described, we have quite a large research program using ultrasound as well as other imaging modalities. So today I only describe one component of our research program, which is focusing on the carotid arteries and assessment of carotid disease and the risk for stroke. So first, a disclosure, we have, as described, we have quite a few licenses to companies, as well as we have spun off companies and contracts with companies and so on. So these are the companies currently involved with our work. So first, I have to describe what we are doing. What is this subject about? So the carotid arteries, as you can see in the figure, are the arteries supplying blood to the brain. So they're very, of course, very important. And because of lifestyle factors, genetic background, and so on, lifestyle, disease, the atherosclerotic disease, or hardening of the arteries, as some people call it, develops in the arteries in the body, but primarily in the heart and the carotid arteries. So the arteries are on both sides of the neck, and they go up from the aorta or the heart and supply blood to the brain. So if there's plaque there, or this atherosclerotic or fatty plaque deposited in the carotid arteries, then it poses a potential danger to the patient, because if a piece of plaque breaks off, it can travel either to the head, to the brain, or to the face area because of the branching pattern. If it travels to the brain, then these piece of plaque can actually block a smaller artery in the brain, and therefore cause no blood flow in a part of the brain, and that is a stroke. And so it could be quite deadly, or cause the patient to have a terrible disability. And we're all familiar with that. Maybe you have knowledge about elderly people in your family or so on who are at risk for this, or even have had this situation. So it's a very serious situation. How to deal with that? So one way to deal with it, of course, is drug therapy, statins. So if it's diagnosed, if an individual is diagnosed with plaque disease in the carotid arteries, then one can take statins. There are expensive drugs and certainly available in Canada, or dietary change. So basically change diet to reduce the progression of the disease, so it stops, and lifestyle change, more exercise, better eating, and so on. So there are ways to actually stop the disease from getting worse and cause a stroke by changing diet, reducing weight, exercise, and of course medical intervention like drugs. So it is very important to be able to diagnose the disease, and so that's and typically it's done with ultrasound. As you know, ultrasound is very inexpensive, available in just about all hospitals, and so you put an ultrasound transducer on the neck, and you can see the carotid arteries clearly, and you can see plaque very easily. So a patient can be diagnosed and come back a year later to see if things change. But there are limitations to ultrasound, conventional ultrasound, which is used everywhere, by the way. So it's a manual approach. So assessment of the plaque, how big the plaque is difficult. You can get the area, but maybe not the volume. So it's difficult to know exactly if the plaque is changing. So it's difficult to come back a year later and put the transducer exactly the same location to see if the plaque has changed, because it could be a few plaques, not just one, but it could be 3, 4 even. So it's difficult to know if the plaque has changed, because it's difficult to reproduce the imaging, and therefore, and of course, monitoring of therapy. If a patient is diagnosed and they start changing diet and lifestyle, and then they have to come back possibly every year. In our clinic, they come back every year or 6 months, and they have to be monitored to see that actually things are getting better. And of course, it's difficult to compare between different clinics. If you go to a different clinic, you may have a different ultrasound machine, so results can be different. So our goal for research was to develop tools to quantify carotid plaques from 2D and 3D ultrasound images, from 2D as well as 3D. So be able to understand the 3D distribution of plaque, the area and the volume of the plaque, depending which method is being used, and identify the surface characteristics and composition of the plaque. So these are the goals, and therefore, using this kind of inexpensive imaging modality, ultrasound, as you may know, the machine can cost, it's the cheapest machine. You can buy one for $10,000 and up to about $300,000. So you can get, so there are very low cost portable machines available, used in hospitals in North America for sure. So this is the device we have built. It's very simple. This is for 3D ultrasound acquisition. You can see this just on the left side. You can see the device. It's very simple. It's a motorized device. The individual holds a transducer, places it against the neck, holding it still and activating the motor causes the ultrasound transducer to slide along the neck, and we collect the ultrasound images from the ultrasound machine into a computer via video frame grabber, and then build the 3D image in using our software. So all that is fairly straightforward and not very expensive. And these are kind of images we can get. So you can see, if you can see my cursor, You can see the black is the vessel, the blood. Blood doesn't give a strong reflection, so it shows up black. The tissue muscle shows as grayscale, and so this channel should be open, and there you see a plaque. And you can see it's sitting right at the entrance of this vessel, and this vessel goes into the brain. So if this plaque, a piece were to break off, then this patient would have a stroke. So, so you can see how easy it is to generate a 3D image and look and analyze it and see this plaque. Another patient, there's another case, and here you can see this is a view, cross-sectional view of the carotid artery, and you can see the plaque is all the way around the carotid artery. All that is a fatty deposit and some calcifications in it. And there's the same patient just cut from the 3D image is cut from the side, and you can see the plaque, and it's fairly big. So imaging is using this technology is fairly straightforward. So one can start analyzing the images. So we can use manual tools. I'll get to automated tools a bit later. But first, before deep learning became quite available, we use manual tracing tools to trace the artery and the plaque. And you can see different views. We can trace it, trace the plaque, as you can see in the bottom picture, the plaque, very heterogeneous plaque with calcifications and fatty deposits, a fairly large plaque, and then this can be displayed in 3D. So this patient, we can quantify how much plaque this person has. It's 637 cubic millimeters of plaque. So if this patient has therapy, undergoes or lifetime style change, then we can measure it again and see if it changes. So here are some other examples, just different ways of looking at the plaque. You can see this, the same plaque is shown in, more graphically. We can show this to the patient to scare the patient, so the patient changes diet, stop eating fatty food and losing weight, and starts losing weight. This is a large plaque, 964 cubic millimeters. And there are also some small plaques. So you can see 103 cubic millimeters, a very small plaque, and intermediate size plaques. So it's, as you can see, it's quite straightforward now to be able to generate a 3D image and then trace the plaque and quantify it, and then be able to image the patient a year later to see if it changes. So the first thing we had to do is before we could use it in patients to get regulatory approval to use it in the hospital, we have to demonstrate that our volume measurements are accurate. So for that, we use test phantoms first, because in test phantoms, we know exactly what size the plaque is. So as you can see, we created an agar block with a channel in it and put in a plaque into it. You can see the slices of the 3D image. And then we know exactly what the plaque size should be, and we measure it using our software. And this way can demonstrate if our method is accurate. And you can see that the error is fairly small. As the plaque gets bigger, the error gets smaller. So in other words, for intermediate size plaque, the error is only about 3%. So basically it tells us how much change we need to, the patient needs to have in the plaque before we can detect and say that the change occurred accurately. So, but the biggest issue, of course, is variability. In other words, if the same measurement is done multiple times, do you get the same answer? So the accuracy is quite good, but what if the system generates highly variable results? In other words, if it's not repeatable, one day it's one value, another day it's a different value. So that's really critical for managing patients and in clinical trials. So for that, we can use patients. So we did a multi-patient and multi-user observer study where we used 40 patients, 5 different observers, and patients with small disease, 37 cubic millimeters to 600 cubic millimeters. and multiple measurements for each observer of each plaque. So you can see it's a huge number of measurements. So it's 5 times 5 times 40. So this took a long time for the 5 observers to generate. So there's an example of one case where you see the outline of the vessel wall, and this person had 2 plaques. So, and of course, this was the measurement was repeated, and these are the results. So this is ended up being a very important result, and we published it in the journal Stroke, and it generated a lot of interest from pharmaceutical companies for clinical trials in which we ran. So this shows that as the volume gets bigger, the coefficient of variation, or the standard deviation divided by the volume of the plaque, diminishes. But for small plaques, the system is somewhat variable. You can see the coefficient of variation is about 15%. But as the plaque gets to about intermediate size, 100 cubic millimeters or smaller, then the coefficient of variation is 5% or less. And that's very important. It tells us for which plaques we are really sensitive to. And it's really intermediate plaques. Our system is very, very reproducible. And for smaller plaques, it's reproducible, but it has a higher uncertainty of the order of 15%. So this allowed us to be able to decide what patients to enroll in clinical trials, to test various methods of dietary intervention and drug therapy. So in fact, a company approached us to run a clinical trial to test a statin, to see the effect of a statin on the plaque. It's known that statins reduces blood cholesterol, but does it actually change the plaque and reduce the risk for stroke? So for that, we used statin therapy. We imaged patients at baseline and 3 months later. And some patients had placebo. In other words, they got pills, but they were not the drug. They were just fake pills. So they didn't know. And then in 3 months, baseline of 3 months, we tested the difference in the measurement of plaques in these patients. And this is the result. So you can see in blue is the placebo, meaning the fake drug, and in red is the statin, the drug that reduces blood cholesterol. And you can see the horizontal axis is the volume change in 3 months. So you can see in the placebo, there essentially not much change, maybe a little bit increased, the plaques increased a little bit, but basically not much change. It's all around 0. But the statin therapy, you can see that in most cases, the plaques got smaller, reduced in volume. So this was really important because it showed that statin therapy does reduce the plaque size and therefore reduces the risk for stroke. So, and now, of course, statins in North America are used routinely. These are the numbers. As you can see, the statin therapy, on average, the volume change reduced by 90 cubic millimeters, and the placebo increased by about 16 or 17 cubic millimeters. So that's quite a result. So next is we looked at various metrics to be able to calculate the change. Is it just plaque or is it something else? So we looked at various aspects. We looked at vessel wall volume. So in other words, included plaque plus the vessel wall, because although the plaque is the fatty deposit that causes a stroke, the vessel wall can be also inflamed and have includes the disease. So we also looked at segmenting the outer wall of the carotid artery and the inner wall or inner interface between the plaque vessel and vessel wall and the blood. The blood is black, and the plaque and vessel wall is this region. So we looked at that, and you can see we tested it in males and females at different ages to see if there's a relationship between the difference in males and females and as people age. And typically you can see as people age, the amount of plaque found before treatment increases. As you get older, individuals get more and more plaque in both males and females, men and women, and about the same amount. You can see the amount of plaque, it may be a little bit more in men than women, but generally the increase is about the same, a little bit higher, more plaque in men and women. So so here are some of the kind of measurements we've made. We looked at total plaque volume. In other words, looking at how much total plaque, how many plaques, and adding up all the volume of plaques in the individual patient as maybe a metric, rather than looking at a single plaque. All the plaques as gives us probably a more precise measurement. And also vessel wall volume, as I just described, looking at both metrics. So these are the clinical trials we ran, and to look at which methods are better, but all ended up being quite useful, and they provide a little bit different information, some overlap, but somewhat different. So when we looked at changes in these patients, the question the doctors asked us is, where are the changes happening? Can we map out the change specifically? Because if the plaque is still at the entrance of the internal carotid artery that leads into the brain, then it's very dangerous. But if the plaque changes elsewhere, then maybe it's not a big factor. So we began to look at methods to map the changes in the plaque, or even just a method to show where the plaque is, and the change. So there's an example. This is a manual tracing of the vessel wall, and we can and the plaque, and we can map the thickness of the vessel wall plus plaque onto the surface. So we can see that, for example, where it's blue in this image, then the variation in the measurement is quite low, but there's not much plaque there. And where it's colored, then there's much more variation, more change. And this is looking just at the channel, the blood channel, and again, the same kind of thing. So we can measure the channel quite accurately, the vessel wall a bit less accurately, and we can show to the physician, the doctors, graphically exactly where the plaques are. And then we can map the thickness of the plaque on a 3D graphical display of the carotid artery. So there's an example. There's the bottom of this bifurcated vessel. The bottom comes up from the heart. The big fat vessel goes into the brain. The other branch goes to the face. So in this patient, there's more plaque right at the entrance of the vessel going to the brain, and a lot more plaque going towards the face. And for this, we can quantify different metrics, and we can then also ask, where is the change happening? And so there's an example. That's the baseline. So we looked at a clinical trial where individuals had statin therapy. So this is the baseline image where there's a lot of plaque. This region is a lot of plaque. And so there's another case where it's time 0. The middle panel is time 0, and 3 months later is shown on the left side. And if you subtract these two images, the 3D subtraction, we get a map of where the change is taking place. So green is no change or very little change. Blue is reduction in the plaque volume, and yellow and red is increase. So in this patient, we had a decrease. This patient had the statin therapy, so there is a decrease in the plaque, and it's a little bit increase also. So it's but the net was a decrease. And then of course, the physicians didn't like a 3D display because they needed a computer for that. They asked us to be able to cut the artery open like you do for pathology, to show the map of the artery in that kind of as a 2D display of the 3D carotid artery. So a student developed this method, basically the same data. Now you cut the vessel open, all in the computer using software, and at 3 months later got this map, and you can see the increase and decrease. The red is increase, and blue is basically not much change. And then by subtracting them, you get a map on the right side. You can see green is right in the middle with no change, red is increase, and in this case, blue shows as a decrease. So this kind of display, it can show the details of where the plaque is changing, where it is, and where it's changing. So the student who developed this method now is, of course, he graduated and has continued this research and is published extensively about this kind of method and analysis. So the next thing, of course, many of these measurements were done manually. And of course, manually is very time-consuming and very laborious. It requires a fair amount of time. You need an expert person. You need to train individual. So it's manual measurement really is not a good future for any quantification or management of these patients. So really, we needed to find an automated methods. Obviously, deep learning is the way to do it. So we have developed methods, machine learning, deep learning methods to quantify plaque automatically, both in 2D and 3D. So we published a number of papers. If you're interested in those, you can just search my name or email me, and I can send you papers on deep learning based methods to quantify the plaque. So we've developed 2D obtained carotid images to test our methods. We collaborated with a colleague, a student of mine who was in China, who finished and went to China. So we continued to work together. So we had images from London, 144, and 497 images from a hospital in China, and developed various methods. I'm only describing to you one paper, but we published a few papers, probably a half a dozen to a dozen now. So looking at different methods to quantify different aspects of 2D and 3D. So in this case, for 2D methods, we use UNet++, which is an ensemble of 8 networks in a backbone all together. So the idea is that using 8 networks using UNet++ will give us better results when we have small number of images. In this case, we have about 500 images. And so it's still not thousands. So with 500 images, UNet++ should be able to quantify individual plaques better and be able to assess total plaque in the patient for management of the patient. So I'm not going to describe the algorithm, but basically the images get input into UNet++, into basically 8 backbones. So it's essentially eight UNet algorithms with different backbones given with different sensitivity to the images, and then these generate 8 different results, in which are then are used to coalesce into a final prediction of the plaque. So this is in general the method that we use. So there's an example of the data we had. So from London, Spark is the clinic in London. We have the plaque area is at the top left corner of the image, and you can see the distribution of plaques. And total plaque is, of course, has more plaque, and the distribution is shown on the top right corner. And you can see for total plaque area for these patients, there's still not a lot of plaque, but because they are being diagnosed early and then treated. So nowadays, people don't come to the clinic with a lot of plaque. They are still early stage, and therefore they can be managed effectively. In China, you can see that the distribution of plaques of patients coming to the clinic is smaller. It's interesting that it's smaller than it is in Canada. Maybe because of maybe in Canada some people suffer from overweight, so they have more plaque. And you can see the total distribution of plaque in these patients in China typically are small plaques, and with not much plaque compared, so the bottom right compared to the top right. It's very interesting, but that's the data we used. So we had small plaques and larger plaques, but not huge plaques in our analysis. And these are the results. You can see the red is manual tracing and the yellow is the algorithm prediction. And you can see that in each of the boxes, they're quite good. Even a tiny plaque on the top right corner, the two match very well. And, and the other ones also, they match quite well. So basically, the algorithm is able to predict the plaques quite accurately. But remember, these are small plaques. So we can look at the correlation of manual plotted on the bottom horizontal axis versus the prediction, the algorithm measurement on the vertical axis. And you can see, if you just look at the two panels on the left side, you can see that the algorithm and manual really fit quite well. And this is the bottom plots are the blend alternate plots, which essentially plots the algorithm minus the manual. In other words, the difference between the two compared to the vertical axis, which is the algorithm minus the horizontal is the mean of the algorithm and manual. So the algorithm plus manual divided by 2, and the vertical axis is the difference. So it's a common plot to plot to compare two measurements. And if you ever publish papers and compare two measurements, these are the plots you should have. And it shows the distribution around bias, if there's a small bias. So, but in any case, they track quite well. The previous was the data from Canada. This is the data from China. So it's all, you can see the clustering on the right-hand panel. It's all around small plaques, a huge number of small plaques in the data. But nonetheless, the algorithm is able to predict or segment the plaques quite accurately. And so if any of you are using machine learning tools, maybe you're familiar with the dice similarity coefficient, which is an overlap metric and between algorithm and manual. And you can see UNet++ gets a result for 85%, which is quite good for these small plaques. Remember, these are small plaques. And so the dice similarity coefficient is very difficult to get high performance on small objects. Nonetheless, we compared it to other methods, and you can see it performs much better. The difference in total plaque area between algorithm and manual is very, very small. It's in 2D, it's 0.1 millimeter squared. So basically, the algorithm and manual are very, very close on average, with very high correlation. So the method looks really good. So I think this is essentially a very snapshot of the work we're doing. We're continuing to do this work and collecting images and collaborating with colleagues in China and in Sweden and elsewhere also, who are using ultrasound to monitor carotid plaques to be able to see a change in response to therapy, because the important thing, it's easy to diagnose the disease, but very difficult to monitor changes of the disease. And this is where I think this technology fits in. So describe to you instrumentation and software for analysis. You can analyze it in 2D or 3D. You can analyze it in terms of change, location of the plaques, and the change in the plaque volume. Basically, our technology interfaces with any ultrasound machine. It doesn't require a special machine. It just requires a computer and software, and an interface between the ultrasound machine and the computer. And therefore, we can generate plaque measurements of plaque area, plaque volume, or whatever the physicians are interested in. And now what we are working on is developing software to characterize the plaque. So up to now, I described volume and area, but what's also important is another aspect of the plaque. Is the plaque likely to cause a stroke or not? And that is a more difficult thing. So it's basically characterizing the plaque as a dangerous plaque or not dangerous plaque, because not all plaques are dangerous. Some of them, some individuals can live a long life with plaques in the carotid arteries, and others can have a stroke early in life. So it's important to be able to not just measure the volume or area, but to characterize the plaque as dangerous and not dangerous. And so we are working on these kind of subjects now, of progression, regression trials, and with many collaborators all over the world. So, so this is a quick snapshot. Of course, we have many other projects. We have projects we're working on prostate brachytherapy. If you're a medical physicist in radiation oncology, then you may be familiar with brachytherapy. So we have 3D ultrasound guided prostate brachytherapy, gynecological brachytherapy. We have devices we have developed for 3D ultrasound guided liver tumor ablation to guide needles into the a tumor in the liver and to ablate it, destroy it. And we have other techniques to image the thyroid, to monitor the thyroid using machine learning tools to see if patients have nodules and they need biopsy. So we have quite a, and more recently we have developed a 3D ultrasound whole breast imaging system. So you can see we have because we have many projects, we have a big team, we have many postdocs, grad students, we have visiting students from China. And in fact, we have a visiting professor from Iran in my lab now, many software developers and engineers and collaborating physicians. So with that, I thank you for your attention. I'm happy to answer any questions if you have any questions.
Thank you, Dr. Fenster, for your presentation. Actually, it's very interesting information you provide us in this presentation today. Now we're opening the floor for the questions. I think we have a question from Tabarak. Tabarak is Salmani.
Yep.
Yes, please go ahead.
Thank you. Thanks for the presentation, and it's a nice and informative one. And I have a few questions. Hope that you'll be patient with me. First of all, how long does this exam take when you use the 3D plaque ultrasound? So how long does it take with the patient? So is it a time consuming or
yeah, so it takes 8 seconds to acquire 8 seconds, very fast.
Yeah, so fast, yeah. Okay, then, and how do you control the reproducibility of the setting for each patient? So for the same patient?
Yeah, so that's a good question. So of course there's a few settings. So one set of settings is the ultrasound machine. So so the ultrasound machine, typically the sonographer, the doctor, usually sets up the machine for optimal viewing of the plaque. So we can't really control it too much because the doctor sets up for best view of the carotid artery, and ends up. So the differences are really almost none that we can detect between the settings. If a patient comes back the second day, it's almost essentially the same. And then for 2D, it's 2D. The biggest issue is positioning of the ultrasound transducer on the neck, and that's more difficult to control.
Okay, can't you just connect it to a stepper and you can control it automatically, or that doesn't work with it in this case?
Does which work automatically?
So to transducers, you connect the transducer to a stepper, so automatic stepper, and you can control it in this way, right?
Yeah, it's automatic. So for 3D, it's automatic. You just push a button and the motor translates. For, of course, 2D ultrasound, it's very straightforward, right? You just have a collect, the doctors collect ultrasound images into the computer and you just get them.
And what do you think the future of this technique can use during surgery or during radiotherapy? You know, I know that it is you said that it will be used, or it is used with the brachytherapy, but yeah.
So 3D ultrasound we use it in prostate brachytherapy. In fact,
Yeah.
we have licensed our technology to Varian for use in prostate brachytherapy. So a 3D ultrasound guided prostate brachytherapy. And now, of course, brachytherapy procedures can be done under 3D ultrasound guidance. And then we're also developing 3D ultrasound guided prostate brachytherapy, so for gynecological cancers. And then we're also working with Varian on that to be able to localize the applicator or needles accurately with relationship to the tumor. And so the increased accuracy reduces the irradiation of sensitive organs, organs at risk.
I know that in the CMRP UOW, Australian UOW, they work on also with ultrasound for prostate brachytherapy, and they use the triangulation method, I guess, with that, right? So do you have any cooperation with them, or?
No, we work well for prostate brachytherapy. We have licensed the technology to Varian.
Okay.
Yeah. So. And also we developed a 3D ultrasound guided prostate biopsy. So this is a biopsy system. And we have also licensed that to 3 different companies.
So it's in a different line, you can say that. Yeah.
Yeah.
Yeah. Okay. Thanks a lot.
Okay.
Thank you very much, Tabarak. Dr. Ala, you have a question?
Yeah. Thank you, Dr. Aaron, for this great talk. Dr. Aaron, in addition to know the plaque volume, the analysis of local variation in surface deformability resulting from plaque surface motion may provide information of plaque fissuring or rupture. The question is, do you think the 4D ultrasound imaging provide more accurate diagnosis in patient with carotid stenosis? Thank you.
Yeah. So first of all, there are multiple. You raised a few important points. So looking at surface morphology, you mentioned ulceration or fissures in the plaque is very important, and with a high quality ultrasound, you can see those better than even MR. You can see fissures, ulcerations in the plaque, and those become very dangerous plaques. So there have been a few publications showing that. In fact, you can also, using ultrasound, you can look at neovascularization or small blood vessels in the plaque, which is also very important and becomes a very dangerous plaque. So that can be done with ultrasound. So that's advantages of ultrasound. But it requires a high quality ultrasound machine, high resolution ultrasound machine, to be able to see the small changes. In the surface blood flow, again, to look at measurement blood flow using Doppler technique, ultrasound Doppler, you can look at blood flow and then study the correlation of flow disturbance, like flow separation, or if in a very tight stenosis, is there a jet high velocities that may cause the plaque to break off. So we're not studying the blood flow with Doppler, but other people are doing that. So that's an important aspect of ultrasound. So looking at plaque characteristics, including surface morphology and blood velocity profiles or blood flow disturbance.
Yeah, thank you.
I can't. If you're talking, I can't hear you.
Oh, I'm sorry. Yes, my question is about the device you invented. So, how many cross-section image you take for each distance, for each millimeter or centimeter?
Yes.
And if we increase the number of cross section, can we increase the quality of the 3D image we get from that?
Yeah, so also a very important question. So if to get optimal images, so ultrasound transducers, ultrasound images typically have high resolution in plane, but the beam thickness is, depending on the machine, could be not as good. So in other words, the beam is wider in the elevational direction, in the outer plane direction. So that means if you use NICOR sampling frequency, you should get an image every half of the width of the beam of the ultrasound image. So that's but the ultrasound images are not simple. They're not straight. In going into the patient, they're not just like a slab of bread. They spread, so the thickness changes with depth. So, so therefore you have to optimize what you're describing. You have to optimize image quality. So we typically test for every ultrasound machine, we test the images where we collect 2 images per millimeter up to 6 images per millimeter. So obviously 6 images per millimeter implies a very high quality ultrasound machine with very high elevation or resolution. So we do a test like that, and then so typically on average we collect 4 images per millimeter. So you can calculate, so it's 4. So if you scan 5 centimeters, 50 millimeters, then we have 200 images collected to make a 3D image.
Yes, thank you. So my second question is, do your collaborators in China and London use the same device you invented?
Well,
for taking the image, so they can produce the data to train the UNet and the UNet++.
No, so in fact, we use different ultrasound machines, which is important to show that our methods are generalizable. So in fact, it's good that we don't use the same ultrasound machine. In different manufacturers, different image quality, but the more for deep learning algorithms, we want data from as many different ultrasound machines as possible to train a network. It makes the network, of course, much better.
So I have another question. Have you compared the 3D image you produced with the another imaging modalities,
And
like MRI or something
no,
else?
I understand. We did not. That's a much bigger study, because no, we have never done that. We haven't done that because we get patients from the clinic, and they're examined. They're examined with ultrasound. Not MR is in Canada. So also in Canada it's expensive. So in ultrasound is very cheap. So the doctors don't want to send patients to MR. And even if I did a research study, it would cost a lot of money to get as you saw how many images we have. We're using 500 images, and if it costs about $1,000 per MR study. So 500 times 1,000, it's a really expensive study. So we don't do it.
Yeah, actually you answered my last question about the composition of the plaque or the characteristic of the plaque. So you will work on that. So not only the area and the volume, but the composition of the plaque itself. So
Yes.
now you are working on this.
Yes, we've published a few papers on that using traditional image processing techniques, but now we are looking at deep learning based classification.
That sounds good. Thank you very much.
Sure.
Let's see if we have another questions from the audience. Is there any other questions? Yeah. I think Dr. Mustafa will give a word.
Okay.
Yes.
Okay.
Go ahead,
Thank you,
please.
Dr. Safa. Thank you very much, Dr. Aaron. Really, this is a good presentation. This lecture was very important information. This lecture will be part of a series of valuable and important lectures held by Iraqi Medical Physics Society. We hope that this meeting will be repeated in other scientific lectures. Thank you, Dr. Aaron, for your efforts. Thank you for all.
Well, thank you for inviting me. It was a pleasure to describe our work to you, and good luck to you. If anybody has any questions or want copies of papers, just send me an email.
Yes,
Thank you
sounds
so
good.
much.
Okay.
Thank you. Thank you very much, Professor Aaron. Thank you very much.
Bye, everybody.
Yeah, but
Thank you.
Bye.
Bye. Have a good weekend.
Bye. Thank you.
Thank you. Thank you.